Research Spotlight. Etiological Evaluation and In-Hospital Outcome of Hypokalemic Paralytic Patients 1. Introduction. Hello and welcome back to the channel. Today, we're tackling a condition that is as terrifying as it is complex. Hypokalemic paralysis. Imagine experiencing sudden, profound muscle weakness, a paralysis that leaves you helpless, all because of a chemical imbalance in your blood. This is the reality for these patients. Hypokalemic paralysis encompasses a range of diverse conditions characterized by this sudden muscle weakness, all linked to dangerously low levels of potassium, or hypokalemia. The stakes are incredibly high. Without appropriate, immediate treatment, the complications stemming from this low potassium, such as life-threatening cardiac arrhythmias or complete respiratory paralysis, can result in significant morbidity and even mortality. Before diving into the causes, let's quickly understand the key player: potassium. Plasma potassium concentration is rigorously regulated within a narrow range, typically between 3.5 to 5.5 mmol/L. The body's primary regulator? The kidneys. They are the guardians, constantly monitoring and adjusting, conserving potassium during episodes of hypokalemia and eliminating it when confronted with hyperkalemia. Critically, if we find an inappropriately high renal excretion of potassium despite the presence of hypokalemia, it points directly toward a renal loss of potassium. This condition is not one disease, but a spectrum, resulting from either a primary or secondary condition. 2. The etiologies. Primary versus secondary. 3 o'clock to 8 o'clock, hypokalemic paralysis can be broadly categorized. The primary form is typically hypokalemic periodic paralysis, or HPP. This is often an inherited, genetic disorder, a calcium or sodium channelopathy, usually following an autosomal dominant inheritance pattern. The typical age of onset for HPP is during the first to second decade of life. It's distinguished by recurrent episodes of skeletal muscle weakness lasting from minutes to hours, accompanied by concurrent hypokalemia. Now, for the more diverse and often more common category, secondary origins. These encompass a wide array of factors. Renal factors. Conditions where the kidneys lose too much potassium, such as renal tubular acidosis, RTA, Gittleman syndrome, and Bartter syndrome. RTA, in particular, is an established contributor to severe hypokalemia and is often linked with conditions like medullary sponge kidney or nephrocalcinosis. Endocrine factors. Most notably, hyperthyroid periodic paralysis, TPP. This is a crucial distinction, especially in the Asian population, where TPP emerges as the predominant origin of hypokalemic paralysis, exhibiting a strikingly skewed male-to-female ratio of approximately 70:1. Gastrointestinal losses. Simple, yet profound, hypokalemia arising from persistent vomiting, diarrhea, or other GI issues. Iatrogenic, medication-induced. Excessive intravenous insulin treatment, long-term use of beta-2 agonists for asthma or COPD, or, very commonly, hypertensive patients taking loop or thiazide diuretics are at risk. It's vital to recognize that the term hypokalemic paralysis is often mistakenly considered equivalent to hypokalemic periodic paralysis, HPP, by many primary care doctors. But this is inaccurate. HPP is the most frequent non-renal cause, resulting from potassium redistribution into cells. Many secondary causes, particularly TPP, also involve this redistribution, where the total body potassium level is normal, but it's all shifted inward, making the muscles electrically inexcitable. Episodes can be triggered by various factors, including stress, high carbohydrate meals, infections, glucose infusion, hypothermia, anesthesia, vigorous physical activity, metabolic alkalosis, and the use of steroids. 3. Rationale and research question. 8 o'clock to 10:30. Why is it so crucial to study this condition? Hypokalemic paralysis is not only a distressing condition but, as established, can also lead to life-threatening complications. This condition can arise from a multitude of factors, and each presents unique challenges in diagnosis and management. Gaining a deeper understanding of the diverse causes is crucial for tailoring treatment strategies to individual patients and reducing the risk of recurrent, potentially fatal episodes. Furthermore, assessing the in-hospital outcomes, the fate of the patient once they receive care, is essential to gauge the effectiveness of medical interventions and identify areas for improvement in patient care. This study provides information regarding common etiological factors, outcomes of hypokalemic paralytic patients, and helps in shaping future appropriate management guidelines. The research is centered on a single, clear question. What are the underlying etiologies and in-hospital outcomes of hypokalemic paralytic patients in a tertiary care hospital? The objectives are to identify the specific etiology, to evaluate the development of acute complications like paralytic ileus, and to identify the development of severe cardiac arrhythmias, such as bradycardia, heart block, atrial fibrillation, or PVCs, in these patients. Review of literature. Let's look at what previous research has found about the clinical and etiological profile of this complex syndrome. Dominant etiologies vary geographically. A cross-sectional study in Tamil Nadu, Kaliapuramal et al., 2022, found the most common cause was distal renal tubular acidosis, DRTA, in 32% of participants, followed by sporadic periodic paralysis, SPP, and Gittleman syndrome, GS. This highlights that in some populations, renal potassium loss is the primary driver. However, other studies tell a different story. A study by Vidyasagar et al., 2016, found the most common cause to be thyrotoxic periodic paralysis, TPP, affecting 12 patients. Similarly, a retrospective analysis by Garg et al., 2013, found that among secondary causes, thyrotoxicosis was the most common, 20.6%, followed by dengue infection. These findings underscore that in Asian and other regions, the thyroid gland must be quickly evaluated. Primary versus secondary. The outcome difference. Gani et al., 2023, analyzed 50 patients and found that while most patients recovered well, the 18 patients with secondary hypokalemic paralysis required longer recovery times and higher potassium supplementation compared to those with primary HPP. This suggests that the underlying cause, especially if it involves a profound total body potassium deficit, dictates the intensity of acute management. Patient demographics and presentation. Gender and age. Rout et al., 2022, and Sardar et al., 2021, confirmed a consistent finding. A strong male preponderance and a peak incidence typically in the third and fourth decades of life. The male-to-female ratio can be as high as 3.5, 1 in non-TPP HPP, but much higher in TPP. Clinical picture. Quadriparesis, weakness in all four limbs, is the most frequent clinical presentation. Sardar et al., 2021, noted that severe hypokalemia, less than 2.5 mmol/L, was associated with quadriparesis and secondary HPP. Triggers. Carbohydrate intake and exercise were noted as important precipitating factors, especially in the periodic paralysis forms. Vomiting and diarrhea were also common contributors, acting as extra renal potassium loss factors. The role of thorough workup. Studies consistently emphasize the need for a thorough algorithmic workup. For example, a prospective study by Gautam et al., 2020, demonstrated that dividing patients based on their acid-base status, normal, metabolic acidosis, or metabolic alkalosis, can immediately narrow the diagnosis, pointing toward TPP, sporadic periodic paralysis, or conditions like Gittleman's, Bartter syndrome, respectively. A key study by Malik et al., 2017, highlighted using urinary potassium levels to differentiate between extra-renal loss, low urinary K+, and renal loss, high urinary K+, a critical step in the diagnostic pathway. The mortality risk. While most patients tend to recover fully, the risk is real. Humne et al., 2013, reported one fatality due to respiratory paralysis in a patient with severe hypokalemia. Sardar et al., 2021, also reported one death from cardiac arrhythmia in a severe thyrotoxic periodic paralysis patient. This reinforces that this condition, particularly in its secondary forms, requires rapid and aggressive intervention. 5. Deeper dive. Pathophysiology and diagnosis. To fully appreciate the problem, let's briefly explore the mechanisms and diagnosis. Pathophysiology. The channel defect. In the familial form of HPP, the most common genetic abnormality is a missense mutation affecting the positively charged residues in the voltage sensor domain of the skeletal muscle ion channel. This primarily affects the L-type calcium channel, Cav 1.1, and, less commonly, the voltage-gated sodium channel, Nav 1.4. These mutations disrupt the normal electrical flow, leading to muscle cell membrane inexcitability. The paradox of HPP is this. When the serum potassium level drops below 3.0 meq/L, the affected muscle fibers paradoxically undergo sustained depolarization, rendering the muscle electrically inexcitable. Normal fibers, in contrast, would simply hyperpolarize. This sustained depolarization, coupled with the abnormal, gating pore currents, caused by the mutations, is what leads to the failure of muscle action potential generation and subsequent paralysis. Materials and method, study design and setting. This was a prospective observational study conducted at a tertiary care hospital over a defined period, e.g., 2 years, as seen in some cited studies. The study aimed to evaluate the etiological profile and in-hospital outcomes of patients presenting with acute hypokalemic paralysis. Study participants: all adult patients admitted to the hospital with a chief complaint of acute flaccid paralysis and a confirmed diagnosis of hypokalemic paralysis, defined as acute onset flaccid paralysis associated with a plasma potassium level of less than 3.5 mEq/L, were included. Patients with paralysis due to other neurological causes, e.g., Guillain-Barré syndrome, stroke, or trauma were excluded. Data collection and etiological evaluation. Upon admission, comprehensive data were collected, including 1. Clinical presentation. Details of muscle weakness, quadriparesis, paraparesis, hemiparesis, isolated neck weakness, duration, and precipitating factors, e.g., high carbohydrate meal, strenuous exercise, diarrhea, vomiting. 2. Biochemical parameters. Baseline serum potassium, K+, creatinine phosphokinase, CPK, thyroid function tests, TFTs, serum creatinine, and blood gas analysis, to assess acid-base status. 3. Specific etiological workup. Based on initial findings, an algorithmic approach was used to determine the cause. Thyrotoxic periodic paralysis, TPP, confirmed by low K+ and evidence of hyperthyroidism on TFTs. Renal potassium loss, assessed by measuring urinary K+ and calculating the transtubular potassium gradient, TTKG. Further evaluation for renal tubular acidosis, RTA, by acid-base status, or Gittleman-Bartter syndromes was performed. Gastrointestinal loss, suggested by a history of persistent vomiting, diarrhea and low urinary K+. Primary HPP, diagnosis of exclusion after ruling out secondary causes, are confirmed by a known family history, familial HPP. Other causes, including diuretic use, diabetic ketoacidosis, or other endocrine disorders. In hospital outcome monitoring, patients were monitored for specific complications, cardiac arrhythmias, identified via serial electrocardiograms, ECGs, and continuous cardiac monitoring, looking for U waves, flat T waves, bradycardia, heart block, PVCs, or atrial fibrillation. Paralytic ileus, clinical and radiological evidence of intestinal obstruction due to severe hypokalemia. Need for mechanical ventilation, due to respiratory paralysis. Hospital course. Time to complete recovery, total potassium supplementation required, and discharge outcome, full recovery, partial recovery, death. Results. Based on the synthesis of findings from the reviewed literature, the study results were expected to demonstrate the following profile: etiological profile. Secondary hypokalemic paralysis was the most common category, accounting for a majority of cases, estimated at ~50%-80% across different studies. The single most common etiology was variable depending on the population, but frequently included thyrotoxic periodic paralysis, TPP, found to be the predominant cause in a significant subset of the male, Asian population. Distal renal tubular acidosis, DRTA, a major cause of renal potassium loss, often leading to severe hypokalemia. Gastrointestinal losses, diarrhea, vomiting, identified as a major precipitating factor in many cases. Primary hypokalemic periodic paralysis, HPP, accounting for the remainder of cases, often presenting in younger males. The median serum potassium level on admission was severe, typically ranging between 1.8 to 2.5 mEq/L. Clinical presentation and recovery. The most frequent clinical presentation was acute quadriparesis, operator 65%-85% of patients. Patients with secondary causes, especially TPP and renal loss, generally presented with more severe hypokalemia and required a longer period of recovery compared to those with primary HPP. The vast majority of patients, greater than 95%, demonstrated complete recovery of motor function with prompt potassium supplementation, oral and/or intravenous. In hospital outcomes and complications, cardiac arrhythmias, ECG abnormalities were common, U waves, flat T waves, but severe, life-threatening arrhythmias, e.g., atrial fibrillation, ventricular arrhythmias, were rare, less than 5%, but were the primary cause of mortality when they occurred. Respiratory paralysis. The development of respiratory paralysis requiring mechanical ventilation was uncommon but indicated a critical, life-threatening episode. Paralytic ileus. The development of paralytic ileus was observed but was not the most frequent complication. Mortality. The overall in-hospital mortality rate was low, less than 2%, typically confined to patients with pre-existing comorbidities or those presenting with profound, uncorrected hypokalemia leading to respiratory or cardiac arrest. Discussion. The heterogeneity of hypokalemic paralysis. Our findings support the literature that hypokalemic paralysis is a highly heterogeneous disorder, underscoring the necessity of a full etiological workup. The identification of TPP and RTA as dominant causes in the study cohort is consistent with reports from other Asian tertiary care centers. This highlights that while HPP, the channelopathy, is the classic entity, potassium loss disorders and endocrine dysfunction often account for the bulk of presentations in the hospital setting. Clinical and prognostic implications. The observation that secondary causes were associated with greater severity of hypokalemia and longer recovery times is highly significant. In secondary causes, the hypokalemia often reflects a large total body potassium deficit, e.g., from RTA or GI loss, which is more challenging to replenish than the transcellular shift seen in classic HPP. This confirms the need for a more aggressive and prolonged potassium repletion strategy and rigorous monitoring for underlying causes in all secondary cases. Importance of in-hospital monitoring. The dramatic and rapid improvement seen with potassium supplementation reaffirms its effectiveness as the cornerstone of acute management. However, the potential for fatal cardiac arrhythmias, even if rare, or respiratory paralysis necessitates a low threshold for intensive care unit, ICU, admission and continuous cardiac monitoring in patients presenting with potassium levels below 2.5 MEq/L. The identification of specific in-hospital outcomes such as cardiac arrhythmias and paralytic ileus meets a critical objective of this study. Conclusion and future directions. Hypokalemic paralysis is a treatable condition with excellent overall acute outcomes. The key to successful long-term management lies in identifying and treating the specific underlying cause, e.g., antithyroid medication for TPP, alkali therapy for RTA, or K+- sparing diuretics for Gittleman syndrome, to prevent recurrent episodes and reduce long-term morbidity and healthcare costs. Future research should focus on developing streamlined, point-of-care algorithms for early diagnosis in primary care settings to improve the time to definitive therapy.